Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
Hi, everyone. Dr. Eric Westman here. And, on my channel, I like to review and debunk nutritional misinformation out there. But occasionally, I also interview the movers and the shakers in the low-carb keto world or nutritional and exercise world. And it's my great pleasure to have Dr. Mathew Phillips. I got that right. Phillips with me today. How are you doing?
I'm good, Eric. Thanks for having me.
So it's my great pleasure. I've been pushed by my own patients for years now as they age to teach them how to use keto or low carb with the neurologic diseases that they're developing over time. In fact, several of my patients are kind of taking on their spouses as their little test case for diet therapy. And so with your background in neurology, this is great. And many of my patients are going to be just eyes wide open on your every word on how they could possibly help family members who are suffering or maybe even at early stages of neurologic issues. So for those, assume you're talking to one of my patients who hasn't met you. Who are you? Where are you from? Your training, and how did you get into this area of research on low carb and keto and intermittent fasting and neurologic diseases, including cancer of the brain, which is going to be a fascinating discussion. Thank you.
Yeah, just the 1-minute version. I'm Canadian, and I decided to do a lot of my neurology training in Australia. So I trained in Adelaide and then Melbourne, and finished neurology training in Melbourne at the Royal Melbourne Hospital. And after that, I decided that I didn't want to specialize in a disease process. And that was basically most of my options in neurology, stroke or Parkinson's or something. I wanted to specialize in a therapeutic method. And I guess I was a bit frustrated at seeing my patients, particularly the older ones with neurodegenerative disorders, as you said, not really improving with the standard of care. So I took sort of 3 years out where I worked and traveled and volunteered and did a few different things and opened my mind a bit, and then decided that this idea of metabolic therapy, broadly encompassed in terms of what I do, mainly by fasting, intermittent fasting and prolonged fasting and a ketogenic diet, was something that really needed to be explored as a potential therapeutic avenue. And so I've got my skin in the game and thrown my hand more or less in with metabolic therapy to just do studies and trials to see if it can help people. And I would say so far the results look very encouraging, but I would also say a lot more work.
Before we get there,
Sure.
where did you grow up in Canada?
Oh, okay. I grew up in a small town in Terrace, British Columbia, in northern, sort of in the north of the province, or midway up, about 2 hours from the Alaskan border. So there was lots of snow and trees and bears and not much else, but a wonderful place to grow up.
I made a cameo appearance in a CBC documentary film called My Big Fat Diet, where Dr. Jay Wortman put a community of First Nations folks right north of Vancouver on a low carb diet. I don't know if you've ever watched that film. It's Dr. Jay in Vancouver kind of realized that Jay Wortman is his name, very similar to Westman, but Wortman. And he said, the traditional diet there was kind of like the Atkins diet. So he contacted me, many years ago, and it's a brilliant, beautiful film. They had a documentary team follow the study around, and anyway, I wonder. So I had some wonderful trips up to that part of the world, and learned that the bannock bread, the traditional bread there, hadn't been there very long. I mean, so you think, oh, it's a traditional diet, but it hadn't been there, except for the last 100 years, which isn't really very long in traditional thinking. So I wonder, did you get any nutrition training in school as an undergrad? What was your major?
So yeah, just going back, I mean, some of the local indigenous people where I grew up, the Niska, the Shimshan, and the Haida, yes, their traditional diet was very much beach food. So a lot of very low carb, even ketogenic food. So my going back to the undergrad, my undergrad was actually, Eric, in evolutionary biology, and I did both a bachelor's and a master's degree in that. So 7 years. Um, I took my time to study evolutionary biology, and there was really nothing to do with human medicine in that at all. And I believe that has actually framed my approach to metabolic neurology in a huge part now. Yeah.
Yeah. Well, that took a trip up to the Haida Gwaii area and the beautiful uh, uh, paintings and artwork and the totem poles. And anyway, uh, fascinating background in evolutionary biology. I mean, it occurred to me finally after 20 years of studying this that everyone becomes keto if they don't eat for 2 days. I mean, we store fat on our bodies. You know, that is our source of fuel. But did you ever run across the story that Steve Phinney tells about Ulukan grease and the Ulukan fish?
I know Steve Phinney. I know of him very well, but I haven't heard this story. No.
Well, ask him one day. It's a story for another day where he tried to track down the actual fatty acid composition of this fish. And because people went to great lengths to boil and recreate the fish oil there. But suffice it to say, fish oil was a very healthy thing that for this community. And they called it the sunshine in the winter, you know, as a source of calories. And well, then that's fantastic. I'm sorry, I probably caught you off guard that I would ask you about that part of your life. But so then Australia and now you're in New Zealand. Are you at a university in a position there?
Yeah. So the reason I came to New Zealand was to sort of start in a place where I didn't know anyone and sort of redefine the way I wanted to practice neurology. I'm working in Waikato Hospital. It's the fourth largest hospital in the country by bed size. So just over 600 beds. It's a mid-size hospital. I'm affiliated with University of Auckland, which the hospital is affiliated with. There's only two universities that have a medical school in New Zealand. One is the University of Otago down south, and the other is University of Auckland. So we are affiliated with the University of Auckland. And yes, I have a position with them, but I really don't go up there in any way, shape, or form other than the occasional lecture.
Of course, Karen Zinn has been editor of the journal Metabolic Health, and so actually, I think of New Zealand and keto. I think of the journal of Metabolic Health, but I wondered if you had contact with them, or so. Wait, how did?
Of course, yeah, I know Karen well. Yep.
How did you then what was your first step into the keto world? It seemed like it was GBMs, the glioblastoma multiformes.
In a way, yes. When I was traveling, I remember it was in Asia, in Myanmar, I was reading Dr. Seyfried's Cancer as a Metabolic Disease book and then some of his papers. So in a way, cancer got me excited first. But actually, my first deep dive when I was in New Zealand after a few months of arrival was the Parkinson's randomized controlled trial of a ketogenic diet versus a low-fat diet. That was the actual initial research project that I embarked upon. And I really, I mean, at the time, I didn't know nearly as much as I do now. But, the most important thing is to just start something and you learn along the way. So that was actually the first thing. And then glioblastoma was difficult because I had to form relationships with the oncologists because
so that
yeah.
For those that don't understand the medical world, the oncology doctors generally are in charge of cancers of the brain or other cancers, and so it's not normal for a neurologist to take care of the brain cancers typically. So it'd be more Parkinson's, ALS,
Yes.
Alzheimer's. So that that's Makes sense.
Yeah, so Parkinson's was easier because all those patients were under the neurology umbrella. But as you say, oncology, there's no neurologist in this entire country. I am the only one now who has any significant management input to glioblastoma. So yeah, it took a few years to get those relationships to a point where the oncologists would sort of get on board with a clinical trial. Enough of them anyways were supportive. And yes, that trial is ongoing, actually. But because it's a very long trial, the glioblastoma one, whereas the Parkinson's, Alzheimer's trials we did were much shorter.
Well, so I wonder, there are kind of two ways to go here. Maybe briefly talk about the cancer connection. I've interviewed Tom Seyfried, and I have a couple of questions for you, because Tom seems like it's like, Moses bringing down the tablets, or he knows all this, but I always like corroboration of what he's saying, and then also what have you found to be effective, and can you stop glutamine, and is that really important? All those kinds of nuances. How did you implement Dr. Seyfried's method then?
Okay, so basically our protocol assumes that cancer is largely of mitochondrial metabolic origin, and that a lot of the genetic changes occur later. So the protocol differs from what other people have been using, in that we don't focus on the ketogenic diet. We focus on fasting protocols. So intermittent fasting, that is 1 or 2 meals a day, every day, except when they do a 5-day fast. So that's 5 days with only water, tea or coffee, and some salt, electrolytes. And we layer those in with the standard of care, the chemo and radiation. We layer these in because there's a very standard chemotherapy and radiation protocol called the STOOP protocol. And we layer the fasting and ketogenic diet in with that in a very specifically timed manner. The theory is that we can not only make life difficult for cancer cells as they rely largely on glucose, and this Warburg effect is, I'm sure you and most of your listeners know. And to some extent, we target the amino acid glutamine with the prolonged fast. That does have an influence, but we're not specifically targeting that with a drug, say. And then we basically are trying to improve the body's, beyond sort of choking the tumor cells of their glucose, we're trying to improve their sensitivity to the chemo and radiation, the standard treatments, while improving the resistive abilities of the normal cells against the standard treatments. This is called differential stress sensitivity. So the cancer cells get more sensitive to the standard treatments when you're in a ketogenic state, especially the fasting, and the normal cells become more resistant because they sort of stop dividing and they go into a less of a growth mode and more of a resistance mode, a stress resistance mode to all stressors, including chemo and radiation, because we don't want those standard treatments to hurt the normal cells. And so we're timing things very carefully to try and maximize those two things. And I have to say, at the end of the day, though, what we're really trying to do, I think, deep down is enhance their mitochondrial health and their mitochondrial biology, because mitochondria do so many things. They're like, to me, the center of an ecosystem inside the body. And we're trying to do that. And that takes a long time. So our first patient is past 3 years now. And, we fully recruited. So now it's just a matter of time to see how we go. But yeah, I guess the different sign that we have with a lot of other people is we're concentrating on the fasting and the ketogenic diet. And I think what Dr. Seyfried really needs is more firm evidence, clinical evidence in people to show that this can be effective, because we have a lot of case reports, we have a lot of animal evidence, we have trials in people that are suggestive, but nothing has really made me go, wow. And I think this protocol has the potential to do that.
And so was the strategy of using, this is probably one of the worst tumors, you could ever get, right? Tell to someone who doesn't know about glioblastoma multiforme.
Yeah. So glioblastoma multiforme is an old term that we don't use anymore. As of 3 or 4 years ago, it got split into proper glioblastoma, which is about 90% of them, and then grade 4 astrocytoma. So what used to be called glioblastoma multiforme is now glioblastoma or grade 4 astrocytoma. It matters because the glioblastomas have a much worse prognosis than the grade 4 astrocytomas. So a lot of papers you see about glioblastoma multiforme in the literature now, actually, if you look at them carefully, they were grade 4 astrocytomas, which have at least a double or triple survival rate compared to the pure GBMs. So we are only looking at pure GBMs in this trial. Now, the reason this is top 3 worst cancers to get is so terrible is because it is aggressive and it doesn't spread. It generally doesn't spread. It starts in your brain and expands. Now, that would be not a huge deal for a long time in many organs of the body, like the lung, because there's a lot of room to expand. But as you know, you can't expand inside the brain for very long before you get problems, and the skull prevents the brain from moving very far. So one of the reasons glioblastoma is so terrible is it expands and there's nowhere to go. And also it does infiltrate throughout the brain. You can't even see it on a scan. So even if you cut out the part that's causing the expansion, it will pop up again later, usually within a few months. So it is a terrible thing. And it usually hits people in the prime of their life, sort of 50s. So it's awful. Yeah.
So one strategy, of course, in a therapy that nobody believes in, is to target something that nobody else has an answer for. So that is one. How would you figure out then that this is helping? And because there's no randomized trial yet of it that I'm aware of. So how do you know that things are progressing in a positive direction?
Okay, so the design of our study is that we are following a certain number of people who have decided to go on this program, this metabolic program. And there are almost an equal number of people who were fully eligible for the program, but for one reason or another, not offered it. And so they have all received the standard of care as
So you do have a non-randomized control.
A non-randomized control group. That being said, I think that the average median survival time, that means the time at which half of people have passed away in pure glioblastomas, like at our hospital, it's 13 months, so 12 to 15 months, say. So I don't think I would be very excited to get a survival time of 16 or 17 or 18 months. So it would have to be something that's so much greater that even a hardened skeptic would look at that and at least go, there's something to this. So what we're looking at is, in terms of outcomes, our main outcome actually is sort of feasibility. Can they do this? This is the most intensive metabolic therapy protocol that I know of, in terms of intensivity, the glucose ketone index, getting the glucose down and the ketones up, and also in terms of the length of it for any group of people. So we're looking at the feasibility of, can they maintain this very low GKI, glucose ketone index, which, as Dr. Seyfried and others have, they were the ones who came up with it. You want to keep that low to exert maximum metabolic stress on these tumor cells. So that's one outcome, feasibility. The second is safety, of course, and just do that people get. There's a very specific staging grading system of side effects for cancer drugs and cancer in general. So we're using that to see if there's anything nasty that the fasting or keto diet do. And the third thing is efficacy, effectiveness, and that's mainly 2 things: quality of life, exercise tolerance, all that kind of stuff. So we're measuring that every 2 months. And then the other thing, of course, is survival. So how long do people live? So we're looking at it from many different viewpoints. And of course, to patients, the things that matter the most are the quality of life and survival. So we will have that data at some point. We're fully recruited, but it's going to take a little longer to get the data, and the longer it takes, the better that is, in all honesty.
You want people to live long.
Absolutely.
Who's funding the study, may I ask?
Oh, we just had a small grant. It was about 18,000 New Zealand dollars, be about 12,000 US from the Waikato. Yeah, it's a charitable foundation, Waikato Medical Foundation.
But so the kind of expected NIH researcher in the US, I mean, you don't get their attention unless it's $1 million or something, and I actually grew up in the VA Veterans Affairs health system, which is actually wrote grants that were real expensive. And I didn't know how to pad the grants in order to get the bigger ones. And so I'm this is awesome because you don't need a whole lot of money if you're using a kind of protocol, but you do need to pay investigators and staff and things like that. But it's not the 40,000 people in a trial over 8 years. I mean, the effects can be so big, you don't need many people. So have you calculated out the 95% confidence limit of, if you get 1 or 2 people living 5-7 years, it would be just kind of unheard of with any other, you'll have the comparator group, I guess.
We have the comparator group. Our primary outcome measure by which you base the sample size statistics on, as you know, is actually how many can achieve a glucose ketone index below a certain level.
Okay.
And so
variable.
Yeah. So we have a statistician, a very good one, who calculated that we needed at least sort of 18 page participants, and then maybe a couple more for withdrawals. So we've met that, and we've stopped recruitment. And I can tell you right now that feasibility is going to be shown in a very powerful way. The question is whether this translates, this metabolic shift that these people have done, and they've done an incredible shift, as you know, whether this translates into improved cancer outcomes, and we have to wait and see for that.
Yeah, but that's so important to get this far. And congratulations on doing it with really sticks. And I mean, you're not like a program that's heavily funded. So there are other anyway, we'll get to that in just a moment. But this is fantastic.
Sure.
Just for those who don't know about the GKI, glucose and the ketone blood levels, that is the ratio, and the Keto Mojo will calculate that for you automatically, I believe. So that basically it's a blood test, your prick at home, that people can monitor whether they're on the protocol and in ketosis, right?
That's right. And we actually just use glucose and ketone blood strips. We don't use a continuous monitor. So we just make sure everyone tests their blood every day at the same time of day, and we've chosen sort of bedtime hours.
Is there any long-term follow-up from the case series that you published on the GBNs?
Right. So we did a small case series of 10 patients about, 3 or 4 years ago now. So those patients, yes, the follow-up is that all of them have passed away now, which is normal for GBM. Their median survival was 13 months, so bang on average. Yeah. I have to say, though, that, and that was somewhat disappointing to me, because they did a fasting ketogenic diet protocol with great similarities to what our current one is for about 6 months. The problem is, when we started it in those people, they were all on average about 6 months into their radiation and chemotherapy, almost done. And if this metabolic theory is correct, it's not just about putting pressure on the cancer cells, but also trying to restore the health of the body. And after 6 months of chemoradiation, as you know, it's really tough. The Stoop protocol is really tough for a lot of people. And I think it made me question my approach strongly. But I think what happened there was actually I decided that we needed to start this metabolic protocol right off the top, even before the standard treatments are commenced. And so that was what led to the current one. And so far, the results are nothing like that original case series so far.
Well, you know, I might just add in, editorialize that even though you have equipoise as to whether the treatment is going to help or not, you have to be all hands on deck in getting people to do it, you know? So my sense in the paper that you wrote is that people kind of went off and on, and even you had a sort of a comparison of the tumors, what they were doing when someone was following the diet and when they weren't. So you can have equipoise about whether, we don't know what's going to help, but boy, you better stay on. That took me a while in our clinical trials to kind of realize that, it's okay for me to be excited and keep people on board. And there's often that interaction that's necessary from the doctor. I mean, these are people going through life-threatening, fatal kinds of things. So are you kind of increasing it seems like you're helping more in the aspect of having them stay on it.
It's a huge difference this time. So yes, you must have a supportive protocol and a guidance. As you know, most people can do this. It's just they need the guidance because it's hard at the start, the metabolic therapies, and they get easier with time. Like I don't have to do anything now for someone who's been over 6 months on it, right? They're in cruise control. But at the initial few weeks can be challenging. I guess the small case series, I was a little hamstrung because, I didn't have the full support of the oncology department. They were it was all quite new. But whereas now the support is there and I'm able to take a deep dive into helping these people. And I've created a full sort of email series that I email them every day for the first few months or every second day after a few weeks. And I'm available to help them. So it's a lot of work up front, but as people do it after 6 months or so, the work for me is quite low.
Well, I'm glad you hung in there and are doing it again. Now let's go to something easier, I guess. Alzheimer's and Parkinson's. I mean, these are probably the most difficult. So, but I know I can fix obesity, type 2 diabetes, 90% of the time. So when someone comes to me with a severe neurologic problem, I can't guarantee it's going to work. And so anyway, let's switch to your training in neurology and bring us up to speed on what you've done and learned in the more bread and butter neurology field.
Okay, yeah. So the two main areas of work I've chosen to apply metabolic therapy are cancer and neurodegenerative disorders. And the top four of the latter are Alzheimer's, number one. Parkinson's, this is in terms of prevalence, how common they are. Parkinson's disease, number two. And then probably ALS, amyotrophic lateral sclerosis, the most common form of motor neuron disease, or Lou Gehrig's, I believe they call it in the States. And then fourth, Huntington's disease, which is not as common as the other three, but it's a very difficult one. So those are the four I've chosen to have a look at, and they're the most common four. And I guess most of the work I've done is we performed that randomized control trial of a ketogenic diet in Parkinson's disease about 6 years ago now. And that was the first randomized control trial of a keto diet in Parkinson's. The only trial before that was done quite a lot earlier by Dr. Theodore Van Italy in 2005 or so.
Yeah.
And he had
years
looked at,
ago.
Yeah, years ago. And he put 6 to 7 people in a single control study, one group, no control group, through this for 4 weeks. So we decided to just double the amount of time to 8 weeks. And I had a good control group. Actually, the control group was very strong because the low-fat diet was very good. It had a lot of fiber and it was, no ice cream or beer or any of that stuff. It was full of fruits and vegetables. It was solid group to compare against. And I guess what we showed that despite that really good low-fat group, and we played both diets up really to both groups similarly with the exact same amount of time, videos, emails, and everything to make sure we were treating them both fairly. In fact, one of my co-investigators thought we were making it too hard for the keto diet, and she may have had a point. But the keto diet still came out on top when you looked at the outcome measures. And the most interesting thing was for your Parkinson's listeners, the low-fat diet improved the non-motor symptoms in Parkinson's by about 10%, but the ketogenic diet improved them by 40%. Now, the non-motor symptoms are all the non-movement symptoms that people don't really see as readily. So things like depression, apathy, anxiety, sleep problems, swallowing problems, bladder problems, constipation, you name it. There's just so many of them, and they're more disabling than the movement symptoms. They improved by 40% in just 8 weeks on the keto diet. On the low fat, they improved by 10, so the low fat diet was still good, but keto was better. Our next big trial was in Alzheimer's disease. Now, Alzheimer's, I guess the interesting thing about that was it was a very powerful design, a randomized crossover design, whereas the Parkinson's was a randomized parallel design. So a crossover, everyone gets split into 2 groups, and half did the sort of standard, the healthy recommended diet. So we had a dietitian give them information on how to make their diet healthier, standard of care, and the other half went on a keto diet. 12 weeks, and then we crossed them over, and we did this thing called a washout, where people went back to their original diet, and we made sure they did, although a lot of the people in the keto diet, quite frankly, didn't want to. And after 10 weeks, you try to wash out all the effects of the previous diets, good or bad, and then people who were on the standard of care diet went keto, and people who were keto went standard of care for another 12 weeks, and that's very powerful. That study showed Alzheimer's is the most challenging population I've ever applied this to, I got to say. Just the nature of the disorder. None of them were mild cognitive impairments. They were all mild to moderate Alzheimer's. And so the unique thing about that trial was it was the first randomized controlled trial in a pure population of Alzheimer's. And we showed that we looked at cognition, function, and quality of life as the main outcome measures. The cognition improved, but not statistically significant. So it sort of got halfway to where it needed to go, but it didn't get there. The trend was good. But the function, which actually I guess is arguably the most important variable for someone with Alzheimer's, is how are they functioning in their relationships, in their job, if they're still working, and things like that. That improves significantly in both statistical and clinically meaningful sense, as in it was meaningful to a clinician, to the patient. And the quality of life improved in a statistically significant and clinically meaningful way too. So that study was, I think it was suggestive that, this could have a powerful benefit. And again, that was just 12 weeks.
And how many people in that study? How many people?
Oh, yeah, sorry. So the Parkinson's study, 47, so divided equally amongst 2 groups.
Yeah.
In the Alzheimer's study, 26, which isn't as many, but in a randomized crossover trial design, that is adequate power.
Well, so just to put into context, if you're looking at a drug for treatment of cholesterol levels and statin, usually there are tens of thousands of people in this study, and you're looking at absolute risk, reductions that are really tiny. Here, a signal when you have 40 people like this is huge. So to someone who doesn't understand statistics and power and things like that, the smaller the number and you still find something, the more potency the intervention is. And gosh, I certainly hope so. Are you planning on following up on these studies, or do you know of anyone else who's funded to do so?
Well, I'm waiting to see Dr. Russell Swerdlow over in Kansas is performing a nicely powered Alzheimer's randomized controlled trial. I believe he's looking for about 80 people. So I'm going to wait and see what happens with that trial. I think that could be very exciting. Parkinson's, I know of some smaller trials that have been done, but I think ours is to date still the largest. I would like to do a larger and even better well-designed Parkinson's trial in future. But I have to say right now, the glioblastoma trial is still ongoing, but next year I may look at another trial. We've done some case studies. I don't know if you're aware in ALS and Huntington's.
Yeah.
And those showed some.
Yes, please.
Okay, yeah. So they showed. I mean, I was a bit scared of those two conditions, quite frankly, because they are as hard as Alzheimer's and Parkinson's are. Those two are probably a touch harder. ALS. The reason it's actually it's pretty common. The reason you don't know too many people with it is because people die with it pretty quickly. Not as fast as glioblastoma, but pretty fast, sort of 2 years or so. And we looked at a guy with bulbar onset ALS, which is the worst kind, and he's still doing pretty good. I don't know how many years we're out since the diagnosis now, but we're sort of at the 4 or 5 year level.
Is that in the case study that you wrote?
Yep,
Is
the
that
one that was published earlier this year. So briefly, he had been diagnosed with ALS for about 18 months, declining on multiple levels during that time, including a lot of weight loss. And then I decided, well, if he's had this decline for 18 months, why don't we see what 18 months of a metabolic therapy can do? So we have similar time points, pre-metabolic therapy and during. And then we just measured his, we used the best sort of ALS rating scales and things. We had neurologists come in and assess him, and as well as neuropsychologists and respiratory technicians to look at his breathing and FEV, all these breathing indices and weight, of course, too. And it was really interesting because I can't remember exactly, but he lost about 7 or 8 kilograms or something in the preceding 18 months. It was substantial weight loss. And yet he had barely any weight loss on the metabolic program, which was a 2-meal-a-day fasting protocol. And that doesn't make logical sense if you exclusively subscribe to the calories in, calorie out theory. However, I think that there's more to it than calories in, calorie out. It plays a part to an extent, but there's more to the story than that. And I think what basically happened is that I'm speculating that we sort of improved his metabolism. And if ALS is a largely mitochondrial metabolic disorder as well, then maybe that accounted for some of his improvements, because he improved in a lot of things. His function sort of improved, and his breathing parameters it kept improving at every assessment. Every 6 months, they kept improving, which was pretty wild to me, to be honest, because most of these people die from breathing-related complications and pneumonia. And then we did another case report in Huntington's, a man with Huntington's as well. And I just spoke at the Huntington's Disease Society meeting for our region of New Zealand a couple weekends ago, and he was there. And this is again 4 or 5 years ago that we started this, and he remains reasonably adherent. He's fallen off a bit because various reasons. The main one being the lack of guidance. I'm not over his shoulder and helping him out as much anymore, just a little bit. So, but saw a lot of improvements, and this is a difficult one because Huntington's is like 3 things. It's a movement problem, a cognitive problem, so you get this sort of dementia, and it's also, most difficult of all, a neuropsychiatric disorder. So you get these behavioral problems, anger and irritation and apathy and so on. And he improved the most in that last category, although he improved in the motor stuff, and he stabilized in the cognitive stuff. So, these case reports have made me interested, and I guess I'm looking at clinical trials now as soon as the glioblastoma trial sort of starts winding down, in Huntington's and ALS. I think we need more in them because we don't have much in terms of metabolic therapy for those two at all, in terms of trials that have looked at them.
Do you have a clinical practice that you can talk people into trying something, or are you largely research based?
So I work fully public in in Waikato Public Hospital, and my research is all on the side, but although it takes more time probably than my public work. And I'm the director of the neurology department, so there's a bit of work related to that too, and I do most of the teaching. So I would say the way I recruit is just word of mouth, and then I try to speak at meetings held for Parkinson's New Zealand or Alzheimer's New Zealand, these kinds of meetings, and let people know and do a presentation and let them know about it. And that's, I find, the best way to do it, at least for me, because you sort of get maximal exposure to as many people as possible. And it's in depth rather than, me just sort of mentioning it at the end of a clinic appointment or something.
Well, it would seem to me that the Metabolic Mind Bazuki group would be fascinating and supportive. Have you had contact with them at all?
Absolutely. Yeah, they are. The Bazuki group has absolutely contacted me, and
Good.
they're very supportive. They have offered some financial help. I guess as have a few other people actually. So it's not money that is limiting me; it's time. So I would I may take them up on that in the future, and other groups as well. But right now it's time.
Sounds like you need to clone yourself. A junior colleague, a PhD student, a resident.
Well, yeah, I guess it's partly self-induced, Eric, because my approach is like in the glioblastoma trial, in all honesty, there's no dietitian in the country that is suitable for the fasting protocol. The ketogenic diet, yes, there's a few, but the fasting is just a foreign concept to the way we teach dietetic now.
Karen's in might know.
He might know. Yeah, Karen could do it. But so what I've done is I'm doing the nutritional advice with them. And actually, I think that is, I don't know what you feel about this, but I think that medicine, as it is doctors, we should be well-versed in helping patients do metabolic therapy. I don't think we need to lease it out to a different specialty. So to me, this is bread and butter stuff. Helping someone start a ketogenic diet, a fasting protocol, is something doctors should do.
I share I'm afraid I'm kind of as naive as you are, but no, we don't need doctors. In fact, look how long it took for you to get the GBM folks, to develop relationships. Anyway,
Yeah.
the Society of Metabolic Health Practitioners, I'm on the board, and the whole idea is to bring in other people who are not doctors. In fact, you might be able to get a super user of that kind of program to do the follow-up. And in our company, I teach people online. I have admins who are basically super users who do it. So it's not me giving the one-on-one coaching. I'm just trying to help get the bandwidth to create this because you are unique. It's now getting the growth of having other people, come to you. And I hope that will happen from this video, that someone in your area or even someone now I have people all over the country who are admins doing it virtually. So that initial touch, but anyway, yeah, it's so interesting how it becomes local in every little microcosm. Even going back to the First Nations tribe and area we had to have the chief on board,
Yeah.
And fortunately he was, well, this is just fantastic. A couple questions I had for you.
Sure.
Does the level of ketosis matter? So now, people come to me, they say, doctor, my ketones are 2 or it's only 0.2. And with neurologic disease, what's your sense on how measuring ketones might be helpful? And does the level matter?
The short answer is yes, to an extent. I don't think it's an absolute. For example, I have found that people who have higher ketones are generally doing better. However, people who are diligently following the program and can't get their ketones very high for whatever reason, particularly older men who don't have, who are not obese, not overweight, so thin older men have the hardest time getting the ketones up. And so slip of the tongue there. So getting the ketones up. And I think there are many physiological reasons for that. And I try to reassure them that as long as they're sticking to the program, it's okay if they're averaging a lower ketone level than other people are. But yes, I do find that I'm more comfortable when someone is getting a high ketone level and a low GKI. I have found anecdotally and looking at the data that I have that those people generally have an advantage in terms of outcomes.
And then sometimes there are other factors that do inflammatory markers predict?
I measure the only inflammatory markers I'm measuring is the C-reactive protein, really, uh, and I it stays low in both the control group that I've ever used and also the experimental group. So, look, I think that the thing about these things, what I've found, and which might make it trickier for some people without medical knowledge to implement them in these more advanced disorders, is quite frankly, some people can get worse in the first few weeks before they get better. And it's dealing with the neurological, like you think you abruptly change, we always abruptly change people over to these things like, one day they're a normal diet, the next day they're keto. And Parkinson's and maybe even the glioblastomas, I've found that things can be a little rocky in the first few weeks in terms of their symptoms, which makes sense because you're suddenly totally shifting their fuel source and the body's not ready to utilize fatty acids and ketones to the extent that you'd like. It takes a few weeks to really get into it and months to optimize it. So,
Well, the way I explain it is, see, it's having an effect. I mean, at first it might be a little worse, but it's having an effect. So
definitely,
it's
yeah.
taking something, right? So,
Yeah,
but that does take
that's a good way to put it.
it takes the really the trust, and
Yes.
the trust that gosh, it's I am really thrilled that you're involved here, and I'm kind of reminded where I was, 20 years ago in a different space. It was a different world. I mean, everyone thought I was killing people by having them eat the fat. And then my interaction with Dr. Wortman, coming to a different part of the world was just so important because, I met Adam, a young medical student, and he took us to the cultural center and he said, here's a funereal box. And I said, what's that? And he said, oh, you guys down there, you put people in the ground. It's dirty when they're dead. We bury them in the ground. And I thought, well, isn't that what everyone? So I was so narrow. And well, they put people in a box and then put them in the tree after when they passed away. And it was so culturally different and yet appropriate there. The commonality, though, is we all need protein, right? We all need some fat. These are the essential nutrients, vitamins, minerals.
Definitely the protein. I think if you look at, I've always tried to look at the best data and studies, evidence for something. So if you look at ancestral diets, which I think is what you're alluding to, the best one I know of is a 2007 study by Gervin and Kaplan out of New Mexico, and they looked at many modern hunter-gatherers, and most of those modern hunter-gatherers were on a low-carb or ketogenic diet, and then of the third or so that weren't, most of them were on a low to moderate carb diet, and there are very few that were high carb. I'm not anti-carb, but high carb with a lot of fiber and low fat can be very good. But if you look at things evolutionarily, it's low carb or keto for most people with decent protein levels. And so I think, again, looking at it, that sort of crosses cultures for me. And so it doesn't matter what ethnicity a person is in our trials. Like in the GBM trial, after they do the protocol for 10 months until the chemotherapy and everything's done, I say, what do you want to do? Do you want to go to a more culturally appropriate one that you're familiar with? And yes, so we have Sri Lankan keto, we have Maori keto, we have Mediterranean keto and South African keto, and there's many ways you can do it, but the common denominator is the metabolic state that's induced.
Well, I'm sure it occurred to you that it's one thing to look at the past, but we need experimental research going forward.
Absolutely, yeah.
So, I mean, we might even come up with a diet that's better than was possible before, right?
Yes.
Yeah. So
my number one bulwark is human interventional trials. You need those. That's how you must be guided. Absolutely. Evolution is also powerful, but you need that data.
Well, it sounds like maybe you were touched by the evidence-based medicine group at McMaster, or anyway, that was my training in the early 90s with David Sackett, and Peter Tugwell, Brian Haynes are still there, but yeah, the requirement, even in humans, I mean, we need ideally randomized trials. Although if you take someone who always dies, like someone with meningitis or pneumonia, and they live with penicillin, you don't need a randomized trial. I mean, so you don't
That's
have
right.
to, so, but this methodologic basis is really important because you are fixing or seeing a signal with very few people relatively compared to drug trials where
Yeah.
the potency of the drug is so low. You need thousands and thousands of people. So anyway, follow that clinical signal. It's called clinical epidemiology at the group at Yale, and then David Sackett and the group at McMaster. And then I hope you can tap into the group, Karen's in Journal of Metabolic Health. I don't exactly know what they have there, but they certainly have contributed a lot to this area. And this is hard work. I mean, I really, again, want to say thank you for hanging in there and clearly wanting to make a difference in improvement. That's why I couldn't do neurology in the 1990s or even rheumatology. And it was only after seeing a couple of my patients do their own diet, you know, reading the Atkins book, fixing themselves, that this came to my attention. So you got to follow that clinical signal, and I hope there's a way that you can capitalize on the Bazuki group. At the moment, this is unique that they are having such influence. Hire someone new quick. You know, invite someone. There's a professor in Cherbourg who in the neurodegenerative disease in Canada who's trying to hire a francophone keto therapeutic endowed professorship. So
I think that'd be Dr. Kinane. Would it not be? Yes. Yeah.
Steve Kinane. So
yeah, he's a good guy.
Yeah. Well, again, thank you so much for taking time to talk about your research and clinical care and your background and story. Any last thoughts? How can people find you? It's a metabolic neurologist, isn't it?
Yep, metabolicneurologist.com is the easiest way. I have one social media account on X as well. It's at Dr. Mathew C.L. Phillips. Those are really the only two ways, but I'm happy to correspond with people as they need.
Excellent. And I guess the take-home point is the ketone for my patients. The ketone level may matter. And have you gotten into exogenous ketones at all?
I have tried them copiously on myself, but I do not apply them to my patients because I'd rather get that endogenous ketosis going. I found that for various reasons, I think that's more important. And quite frankly, there are other ways to elevate the ketones with, even just more coconut oil or butter or something like that.
Coconut oil. Well,
exactly.
I don't know. I'm eyes wide open. I'm kind of how should I say, a critic of the exogenous ketones, yet I'm supportive of research and the signals here and there seem really interesting. So what I've seen over the last 10 years, the palatability of them have progressed so that that's not an issue. But now it's the type, and then companies don't seem to be wanting to do research on in medical areas. So you might have to cobble together someone else funding a study to add but I think that's a great area for research to add that to a keto diet, if at all possible. But just as kind of a last thought, how funny the world works in the cardiology space, a drug called SGLT2 inhibitor has been found to reduce recurrent heart attacks. And so it's being used widely. And it's thought now that the way it works is by inducing ketosis in people. And so the cardiologists now are giving people ketone drinks to induce ketosis to get the effect, and the heart is working better in short-term studies. And it hasn't occurred to them that they could do this just by diet alone.
Well, there's a
It's kind of fantastic.
there was a nice randomized trial that just came out a few weeks ago of intermittent fasting protocol in heart failure, done by a German group, and they showed that a few weeks of intermittent fasting compared to a control group eating the same diet but not fasting had improved cardiac function, and they measured it 2 different ways with both MRI and echo. So I think I think the potential for metabolic therapies in medicine is huge. And if I was going to, as a last, leave a parting word, it would say it would be that the single most important intervention that I think most people could embark on to improve their health today would just be an intermittent fasting protocol, period. If you can get that down pat, then you can start working on low carb keto and stuff and improve things even more. But just getting that 4 to 6 meals a day down to 2 is huge. It's a massive win and a drastic change that would really do a lot of damage against the lifestyle disorders. So that's the cancer, atherosclerosis, neurodegenerative disorders, and of course the metabolic syndrome.
And then to change now, right? Don't wait for the neurodegenerative disease. It was kind of shocking to me to hear that it takes 20 years of insulin resistance before there's a symptom, and that by then it's typically too late for Alzheimer's patients.
Yeah, I see the metabolic syndrome as sort of moderate level mitochondria dysfunction or impaired biology, and then those other lifestyle disorders, the top 3, the atherosclerosis, cancer, neurodegeneration, is sort of advanced level mitochondrial disorders. And yeah, maybe it's hard to get full recovery at that stage. Maybe you can't, but I think you can get partial at a minimum. But we need the trials to show that.
Absolutely. Again, thank you so much. I'd like to keep in touch if that's okay.
Absolutely.
All right. Take care now. Have a great day.
Thank you.
Bye-bye.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.